Start my video so you can see who I am. It's not a talking head, or I shouldn't even say like a headless body, but yeah. Okay. All right. It is 7 o'clock. So I'm going to get going. I always try and cover as much as I can in an hour, and I usually put too much together, but I'm trying to give you everything that you will need in an hour. And so I'm going to get going. As people continue to join us, I'll just continue to let them in. All right. So tonight's the lymphatic system. So as far as the NPTE, this is a smaller section. About 3.3% of the NPTE is lymphatics. However, in my experience, I've had students who have failed by a small amount or passed by a small amount. And so what I tell people is, if you can, you really want to make sure your review for the NPTE covers everything, because it may just be those few questions that get you to that 600, which is what you need to pass. So with lymphatics, we have PT examination. You're going to see 1 to 2 questions on that. Differential diagnosis, evaluation, prognosis, about 2 questions. Probably about 3 in intervention. They say you can have 4 to 7 questions on the exam. All right, so we're going to do all of these tonight. We're going to do a mix of all of this tonight. All right, so the first thing we're going to talk about is differential diagnosis. I think this is really important. They're going to give you questions on the exam, and they're going to say, hey, is this lymphedema or is it not? Are you thinking they've got something else going on, or do you really think it's lymphedema? Also, if it is lymphedema, what stage of lymphedema is it? Can you figure that out? Okay, so those are the first few things we're going to cover. So the first thing is a stop and think. So what we're gonna do is just address lymphedema right now, that top row. That's what I want you guys to look at. So what I want you to ask yourself is, with somebody with lymphedema, do they have pain? And if they have pain, what's the severity of pain? Color, does their skin change colors? Yes or no? Does their tissue or their skin get fibrotic or hard? Yes or no? Are they at high or low risk for an infection? And I'm thinking skin infection. Is their foot involved? So does their foot or hands, either one, will those get edematous as well, or will they not have edema? Skin mobility, will their skin be mobile, or will it be hard to move their skin? Stemmer sign, we're going to go over what that is, but if you remember, what I'm looking for is, do they have a stemmer sign? Yes or no? And then the last column is, if they have lymphedema, where typically do you see the edema? Okay, so I want to give you about 5-10 seconds to look at that and think about what you would put in each of those blocks.
Do you have a PowerPoint that you're referencing, or you're just like,
So this is my PowerPoint. We don't share the PowerPoints, but this is being recorded and it goes on
oh,
YouTube.
okay. Sorry,
Yeah.
I didn't see the PowerPoint at first. My apologies.
Okay.
It's okay. I
Yeah,
see it now though. Thank you.
yeah. If you're on your phone, sometimes you don't see it unless you swipe or whatever, but yeah. Yes. I shared my screen. Hopefully everybody can see that. Okay, let's look at lymphedema. All right, with lymphedema, they might have pain, but usually they don't. And if they do, it's very mild. So one of the things that would perk your ears up, if somebody came in, they had a lot of pain, you'd be like, is this lymphedema with something else, or is this something else? Okay. Color change. Their skin can have a color change, but it's usually in the late stages. Like the early stages, you're really not going to see a change in their color of their skin. Tissue fibrosis, their tissue getting hard. That's what fibrosis means. It gets hard. You will see that in the later stages of lymphedema, but in the beginning stages, you don't. Infection risk, yes, they have a high risk of infections, skin infections, especially in the last stage, which is stage 3. If they have lymphedema, yes, they will have edema of their hands and their feet. So if they have edema of their upper extremity, their hands will be edematous. If they have edema of their lower extremity, their feet will be edematous. But there are some conditions we're going to talk about where you don't see that. So if I've got somebody that's got a lot of swelling in their arm or their leg, but their foot and hand is not affected, I'm thinking this doesn't seem like lymphedema. Okay. Skin mobility, yes, it's restricted. So these kind of go hand in hand. If I have tissue fibrosis where my tissue, my skin is getting hard, then I don't have good mobility of my skin. So it will be restricted in those later stages. A stemmer sign, we're going to talk about that, what that is in a minute, but yes, they would have a positive stemmer sign in stages 2 and 3. And then when you're looking at somebody with lymphedema, usually it's unilateral, one arm or one leg. Now, some people with primary lymphedema, which we'll talk about, can have bilateral, okay? Somebody who's had a bilateral mastectomy can have both upper extremities involved, but typically it's unilateral. So as soon as there's bilateral swelling, I'm also starting to think, could this be something else? And I need to look at all these other things to determine if that's the case. All right, venous insufficiency. See if you can answer these questions. So look at the top there. Do they have pain? Do they have color change? See if you can fill in the blocks. I'm going to be quiet for a little bit, and then we'll come back and talk about it. Okay, let's look at venous insufficiency. So pain, again, they don't have a lot of pain. And if they do, it's mild. That's a difference from arterial insufficiency. And we're not going to go into the into the vascular stuff tonight. This is supposed to be about lymphatics, but somebody with arterial insufficiency usually has a lot of pain. Somebody with venous, usually not too much. If it is, it's mild, right? Okay, so that's the same as lymphedema. Color change. Yes, with venous insufficiency, when it becomes chronic, they have that chemosiderin staining, where the bottom of their leg will get that brawny, brownish, reddish discoloration. That would be a sign that it's not lymphedema, that it's probably venous insufficiency. Tissue fibrosis, yes, they can get hardening of the tissue once it becomes chronic, and so they won't have good skin mobility. Infection risk is high. The foot involved, it's likely that the foot can be involved. Because the foot's involved, they could have a positive stemmer sign. One of the big differences is it's almost always bilateral lower extremities. Like if somebody has venous insufficiency in one leg, they're going to have it in the other. If they haven't shown signs of it, they probably are. Okay. So again, as soon as somebody says bilateral lower extremity edema, I'm thinking, okay, that could be lymphedema, but it's probably more likely that it's venous insufficiency. All right, look at lipodema and see if you can fill in the blanks. All right, let's look at lipodema. Pain, yes, they have pain. So that, again, as soon as somebody says pain, I'm thinking, could it be something else? Color change, they get bruising, lots of bruising. Okay, so anything they run into, they've got a bruise. Okay, tissue fibrosis, no. Their skin stays soft and supple. So there are no skin mobility issues, there's no restrictions, there's no tissue hardening. So very different from lymphedema and venous insufficiency. Their infection risk is low. Their foot and their hands are not involved. Okay, not involved. And because of that, they're not going to have a stemmer sign. That'll be negative. Their edema tends to be bilateral lower extremities. Okay, can have it in the upper extremities too, but it tends to be bilateral lower extremities. All right, last one, look at congestive heart failure. See if you can fill in those blanks. And then we're going to spend a little time doing a little compare and contrast. All right, let's look at congestive heart failure, right? Because congestive heart failure can cause swelling in the body, right? And so we have to determine, is this lymphedema or is this because, and what kind of heart failure would it be? It'd be right-sided, right? Because that right side of the heart's not pumping really well. And so there's a backup of fluid and it backs up in our body. And I need to change this because we actually don't call it congestive heart failure anymore. It's just heart failure, but it would be probably right-sided heart failure. So pain, no, they don't have pain. And I'm talking about in the extremities where we see edema, they're not going to have pain. Now, if their heart failure gets really bad and they've got ischemia, they could have like angina, like chest pain, but not out in the extremities where we're seeing the edema. Color change, no. Tissue fibrosis, no. Infection risk, low. Foot involved, though, yes. So they can have their feet and hands involved. Skin usually continues to be, mobile. They could have a stemmer sign, but if that foot's involved, okay. Again, where is the edema typically? It's bilateral. A lot of times, towards the end of heart failure, it's going to be all four extremities. Plus, they usually will get it in their abdomen too. And that we don't see as much with lymphedema. All right, so let's do a little compare and contrast. So if they're giving you a scenario and the person's got pain, I would be leaning towards lipodema. If they said there's a color change, I'm leaning towards, well, it could be venous insufficiency, lipodema, maybe the end stage of lymphedema, but I'm leaning a little bit more there. If the tissue is getting hard and fibrotic, I'm going with lymphedema or venous insufficiency. And because of that, they're going to have issues with their skin mobility. When is swelling of their hands and feet not involved? Definitely is going to be that lipodema. And because of that, they don't have a stemmer sign. And then as soon as somebody's telling me unilateral, one arm, one leg, I'm leaning more towards lymphedema. As soon as I hear bilateral, I'm thinking different things. And definitely if I hear it's more in the trunk and abdomen, I'm leaning a little bit more towards heart failure or something else. So keep in mind that the question on the licensure exam is not just going to give you, you're going to have multiple clues. Okay. And it's just, you're going to have to put these together to figure out what's going on. So it's not like they're going to say, somebody comes in, they have unilateral swelling of one leg. What is it? Right? You don't have enough information to determine what it is. So they're going to give you multiple clues. And hopefully this will help you then kind of narrow it down and say, this is probably the thing that's most likely. All right. So in the chat, what are other potential causes of unilateral edema in an arm or leg? So what else could it be besides the things we just listed? An infection, yes. Somebody with cellulitis? A DVT, yes. Yes, we always want to rule out it's not a DVT. Post-op swelling, yes. Trauma could be, yep. Acute joint injury, yes. Yes, yes, yes. Good. So yeah, every time we see edema, it's not like, oh, this is either lymphedema or, there's could be other things. Yeah. Yep. Post-op surgery compartment syndrome. Yes. Yeah. And then we're looking for vascular changes and those types of things. Good. Okay. What about bilateral edema? What are other potential causes of bilateral edema in the extremities? Heart failure, yes. Would acromegalia cause that in the hands? Swelling in the hands? I don't know. I would have to look that one up. Pregnancy, yes. Medications, yes. Okay. Kidney failure, yes. Yes, good. Okay, so let's look at those. All right, so unilateral, I think we got them, like DVT, cellulitis, infections, some surgeries, some trauma, arthritis, acute joint issues like gout, but usually gout or some other joint thing is only going to be at the joint with maybe some swelling past it, but it's usually not going to be like the whole leg. When it's the whole leg, we're thinking DVT, an infection that's gone untreated, that's spreading, and they could become septic. Bilateral edema, I'm always thinking about organ failure. Whole body edema, I'm thinking about organ failure. So I'm going to want to rule out, is this kidney failure, heart failure, liver disease, severe lung disease? Okay. Before I just jump to lymphedema. Lipodema, if you didn't know what that means, it's a hereditary thing. It runs in families. It's an excessive deposit of subcutaneous fat. They actually have a normal lymph system. It's usually in women, and a lot of times the women see it after a pregnancy or with menopause, or there's some kind of hormonal change, could be even puberty. And so we have to recognize if somebody has lipodema and not lymphedema, because lipodema, our treatments for lymphedema would not help somebody who just has extra deposits of subcutaneous fat. Well, exercise and weight loss would, but all the other treatments we do for somebody with lymphedema would not help somebody with lipodema. Okay. And then I just listed some other conditions down there, just in case those show up on the exam. You know that one is the enlargement of lymph nodes, usually due to an infection. And we can see, and it's an infection, right? Inflammation, redness, tenderness, all those things. And then that last term there is when there is an acute bacterial or viral infection that is spreading through the lymph system. You're going to see that red streaking, and any red streaking is like, oh, this is an infection, right? But that can be an infection that is in the lymph system. Okay, good. Let's get into the stages of lymphedema. Okay, I want you to look at the picture, and I know I'm just giving you a picture, but just based on the picture, can you make an educated guess of what stage this is? Just put a number in the poll. Okay, I got 2, 2, 2, 2, 1, 2, 2, 2, 2. All right. Okay, some ones and twos. Okay, perfect. All right, awesome. All right, this is a picture of someone in stage 2. How do we know it? Because we see a noticeable size and girth of the entire extremity. And so it is proceeded from stage 1 to stage 2. Okay, now we're going to get into all the other pieces here, but I'm gonna keep going with some of the pictures. We'll get there. What do you think this stage is? Some ones. I have some zeros. Okay, so we got it down to 1 and 0. And again, I'm not giving you anything else. On the exam, you would have more. Okay. I don't see any swelling here. I can see the bony prominences. This is actually somebody with stage 0. So I don't see any noticeable edema at all. I don't see any change now I can't see her or his other arm. But I can see that radial, the styloid is really nice in the wrist. And so I think it's probably stage 0. All right, let's look at the next one. We don't know. Yeah, on the exam, I would give you more information. Okay, everybody did really good with this one. Yeah, this is stage 3. I mean, and how do we know? There's an excessive increase of girth and edema. We see it in the foot. We start to see skin folds. The weight of that leg looks like it would be very heavy, debilitating. So we're like, yeah, this looks like elephantitis. Yeah, that was the old term. It looks like it's stage 3. Like, okay. And again, on the exam, they're going to give you some more clues. So this one's pretty easy now. So if you look at the left hand compared to the right, I'll wait if you want to put it in chat. Yeah, this is stage 1 now. Yes. So it's you kind of really have to look to see, oh yeah, I see some edema there. But it's not like super noticeable. And it starts usually distally. We get that distal puffiness of a hand or foot. Okay. All right. So I'm giving you more clues now. Again, using chat. What do you think? Somebody who has pitting edema. It's categorized as spontaneously reversible. Elevation can decrease their edema. They have a negative stemmer sign. They have distal puffiness and no tissue fibrosis. What are we thinking now? Very good. Yeah, we're thinking this is stage 1. Okay, so those are the other clues they would give you with the picture. Okay, so stage 1 is it is categorized as spontaneously irreversible. However, we're not going to hope that it reverses. This individual should be picked up for treatment. It's a puffy appearance distally. They have pitting edema. Okay, it's going to get difficult to see the veins on the top of their foot or hands. They're sweat. They'll get up. They'll tell you, I get up in the morning and it's fine. But then at the end of the day, I have all this swelling again. So elevation right now is helping. So this is stage 1. All right. But it hasn't been there long enough to have tissue fibrosis, and they don't have that stemmer sign. Okay. Well, let's look at a stemmer sign. I've been talking about it. Very common on the exam that you know what a stemmer sign is. The stemmer sign is you look at their second finger or toe, and you're going to the skin of the base of that finger or toe, and you can see the picture there. You're trying to grab the skin and pull it up. Now, if you do this on yourselves, you can grab the skin and pull it up. You can grab that, right? So that would be a negative stemmer sign. If you go to try and pinch it and lift the skin and you can't, right? Because there's so much edema and fibrosis in that tissue, you can't really lift that skin up. You can't really get a good pinch and lift it up. Then that is a positive stemmer sign. Okay. So if somebody has a negative stemmer sign, it does not mean they don't have lymphedema, because we just said stage 0 and stage 1, they don't have a positive stemmer sign. So somebody with a negative could still have lymphedema. However, if somebody has a positive stemmer sign, it is very likely they have lymphedema. Now, we still have to rule out venous insufficiency and heart failure, but it's very likely that that's probably what's going on. Okay. All right. Let's look at the next one. All right. So now we have somebody who's complaining of heaviness and fatigue in their extremity. They have a negative stemmer sign. It's called the latency stage, and they have normal limb girth. Yeah. Okay. I'm trying to follow my chat. Yeah, 0. This is 0. This is 0. Okay. So normal limb girth. I don't see any change in their the size of their limb. They so stage 0, I get this question a lot. Is it stage 0 through 3 or stage 1 through 4? Because if you go online and you're reading, you'll see both. But our clinical practice guidelines are 0 to 3. And I've seen questions on the PET exam, and they use 0 to 3. So I would know 0 to 3. So stage 0 is a real thing. It's non-visible, it's latency. We don't see any edema. And so how would we even know that they have a stage 0? Because there's going to be something in their history. They had breast cancer, they had nodes removed, they had a mastectomy, they had radiation in lymph nodes. There's going to be something that's got us thinking about lymphedema. And then they're going to come in and they're going to say, my arm is tired all the time. It's heavy. My ring doesn't fit quite as well anymore. They can also have like a tingling in their entire arm or leg. Those are the things that we're going to be going ding, 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 ding. Maybe with that history in this complaint, this could be the beginning of lymphedema. They could be in stage 0, and this stage should not be ignored. Like we should pick them up, we should start treating because we could help them like not go any further. Okay, again, they're not going to have a stemmer sign. They're, they're not going to have tissue fibrosis or anything like that at this point in time. And oh, there's something else I was going to say. I lost it. But yeah, we shouldn't ignore this stage. We should pick them up. We should see them. Okay. Yes, as somebody gets stage 1, 2, 3, they are also going to complain of that limb being heavy. But when somebody's complaining about that and we see no edema, we're like, okay, well, this doesn't look like stage 1, 2, or 3 because I don't see any edema. But they've got this thing going on in their history and they're complaining about this. This could be the beginning of that. Oh, I know what I was going to tell you. Lymphedema, if you don't know, develops very slowly. So they could be in stage 0 for a long time. And that's why we need to pick them up and teach them and our treatments and get them going with therapy. Okay. All right. Next one, positive stemmer sign. Okay, I think it's supposed to be pitting edema or non-pitting edema. Fibrosis, not responsive to elevation, and it's a gradual increase of edema throughout their extremity. All right, good. Everybody's got it now. Yeah, so that would be 2. So some sources say they have pitting. I think I'm going to start taking that out because if you really look at different sources and the clinical practice guidelines and everything, usually by stage 2, they don't have the pitting edema. They have non-pitting edema. They don't have the pitting anymore. Okay. So you can remember it as they won't have pitting anymore, or it's going to be a lot less. Why? Because they're starting to get fibrotic. The tissue is starting to get hard. And because they're starting to get hard, we don't have that pitting edema anymore. And because they're starting to get hard, the skin's starting to get hard, we have that positive stemmer sign. Okay. And at this point, it's not responding to elevation anymore. So, yeah. Okay. All right. Last one. You guys all got this one. Positive stemmer sign. They can have fluid leaking from the skin, fibrosis. They can have skin changes, deep skin folds. That hyperkeratosis means really hard skin and tissue. The weight can be debilitating. The girth is excessive. Yes. Now we're at 3. Yeah. And that's called our elephantitis. So their skin can be dry and scaly, like because it's hard. Their skin is stretching. It's like they can get really dry and scaling, but they also can get lots of wounds, and then they get some fluid leaking. They also can get a lot of skin infections, and they can get blisters and all of those types of things, skin changes that can lead to some of that fluid on the leaking or whatever. Okay, good. All right. That keratosis, as I said, is that thickening of the outside layer of the skin. It gets really tough. And that's what that's talking about, that fibrosis. So our skin normally does that. Our skin will develop calluses. So if you think about it, when you've developed a callus from like a new shoe or something, right? That skin's really tough. Well, this will be their whole leg or their whole arm. Okay. Papillomas, you can see that on the bottom right picture. That's where they get these like warts. They look like warts. They're not warts, but they look like wart-like growths. And again, that's typical with somebody in stage 3. And then as you can see in the other picture, they get a lot of skin folds, and they've got to have really good hygiene because that's where they can get wounds, skin breaking down, and they can get a lot of infections in those folds. So if the fluid is leaking, is it weeping? Yeah, it's kind of like a weeping thing. Yeah. And it could be for a variety of reasons. So, okay, what's a congenital or hereditary disorder where somebody is born with abnormal lymph nodes or lymph vessels? What would that be called? Yep. Milroy's, or what's the other one? So Milroy's is a common type of what kind of lymphedema? Anybody got it? Milroy's is right. Primary, yes. So primary and secondary lymphedema, yes. Okay, so primary is it's congenital, it's usually hereditary. The individual is born with an abnormal lymph system. They don't have enough lymph nodes. They have too large of vessels. They maybe, just have limited, and they just don't have the capacity. And so really young, right? They haven't had a mastectomy. They haven't had, cancer or anything. And they present with lymphedema. That's primary lymphedema. And Milroy's is one of those types that it usually presents in both lower legs and feet at birth, or that develops early in infancy. Also known as congenital familial lymphedema or hereditary lymphedema type 1. So, yep. Secondary is mostly what we see. That's somebody who, I think I might have a question though. Let me double check. Oh, yep. I'm going to ask you first. So secondary lymphedema is for somebody who develops it later in life. Why? What are some of the causes? Put it in chat. Surgery. Yes. Infection. Yes. A lymph node removal. Yes. Fluid overload if they have an issue with the lymph system. Right, surgery, Phalaris or whatever that is, radiation. Yes. Okay, good. Great. You guys have got it. Good. Okay, so secondary lymphedema, this is mostly what we see. Mostly it's related to surgery. They've had a mastectomy. They had some surgery that really affected the lymph system. Liposuction is one of those. So somebody who gets liposuction, sometimes it disrupts and they lose lymph vessels. And now all of a sudden they have lymphedema. Lymph node removal. Now they don't have as many lymph nodes to run everything through. That causes lymphedema. Radiation, somebody said that, radiation of lymph nodes, yes. Also lymphomas, like tumors of the lymph system, of course. Infection within the lymph system over time, untreated, can cause it. We don't see this so much in the US, but in other countries around the world, it's parasites. So parasites that get into the lymph system, that's that Phalaris. I don't even know if I'm saying it right. We don't see that a lot here unless somebody's traveled out of the country and they come back and all of a sudden they have it. Obesity, and then trauma. Somebody's had multiple pregnancies, burns where their lymph system has been destroyed. Now they can have lymphedema. I want to make sure you know though, chemotherapy in itself, if that's, they had cancer and they had chemo, but they didn't have lymph nodes removed, they didn't have radiation in lymph nodes, they didn't have surgery. Chemo does not cause lymphedema. Okay, it's these other things. And I want to make sure people understand that. Yes, thank you. In the Phalaris, I don't know how to say it, but yes, that's it. So that's seen a lot in other countries, not so much here. Yeah, great. Yeah, it's like worms or, yeah, gets in there, blocks up their lymph system. So I think if they get to that early, it's treatable. But again, we don't see it a lot here in the US. All right, we're getting into interventions now. What are components of complete decongestive therapy? Now, some people say complex decongestive therapy. Some people say complete, which is what our CPG says. So we're going with complete. I've also heard complete. There's another word sometimes people use. Manual lymph drainage, yes. What else? Compression garments, yes. Exercise, yes. Good. Wrapping, short stretch garments, yep. Anything else? Part of our complete decongestive therapy. Education for sure, skincare. Yep, you got them. You got them all. Great. Yep. So it's our manual lymph drainage, our compression, our exercise. Exercise should always be done with the bandaging or compression garment on. Nail care, hygiene, skin care, patient education, which may include weight loss. So if somebody has lymphedema, but they also have some obesity, they're better off if they can lose the weight. It's going to help with the lymphedema. So we may want to do that too. Massage, yeah, that would be our manual lymph drainage. Okay, good. All right, here's some questions. You don't need to put it in chat. You can if you want, but I want you to think. With manual lymph drainage, which direction should our strokes always be performed? Distal to proximal or proximal to distal? Where do you start manual lymph drainage? So if I'm going to do the arm, do I start at the distal location, like my fingers? Or do I start at my proximal location, like my shoulder? Where do I start my manual lymph drainage? At the distal part of the extremity or the proximal part? Okay, and then where do you end your strokes? So if you start, one place, where do you end? All right, and you guys are blowing up the chat. I love it. Okay. Perfect, perfect. Okay, so I think you've had time to think. Let's look at it. So your stroke should always be distal to proximal. Okay, always be distal to proximal. You're always going in that direction. So you're moving things back to the core, okay, to the heart, to the core, to lymph nodes. You're always moving it, trying to move it back to lymph nodes. Where do your strokes start, though? You always want to start at the most proximal location. Okay, so if I'm going to do the arm, I'm going to start at the shoulder or my supraclavicular nodes or even my chest, and I'm going to go down the arm. As I go down the arm, my strokes are always distal to proximal as I'm going down the arm. When I get to the fingers, I then move back up the arm. So I actually start proximally, go down the extremity, and then come back up the extremity and end at that proximal location again. Why do we do that? We start proximally and go down the extremity to uncork the bottle. We are opening up the lymph vessels. When we get to the toes or the fingers, we then start working ourselves back up again to that proximal location, because now that we've opened up the lymph vessels, we are now pushing the lymph fluid back up out of the extremity, out of the hand, back up to that core. Okay. Good. Activate proximal lymph nodes first. Yes. I always say uncorking the bottle. Some students have learned different acronyms. Somebody said, I can't remember, somebody said something about you have to clear out the traffic, or I don't know. But yeah, you're just trying to open all those lymph vessels up, get those lymph nodes going. And then after you go all the way down the extremity, now we're going to come all the way back up and we're pushing that fluid now back up. Good. All right, another stop and think. And again, you can put stuff in chat. What kind of bandages should we use? Actually, somebody already put that in chat earlier. How much overlap of the bandages should be done when we're wrapping? What instruction about wear time do we give the patient? We're talking about bandaging right now, not custom garments, but what other supplies might you need besides those bandages? Do we do the wrapping in a figure 8 type wrapping or more like cylindrical? And should we wrap toes and fingers or leave them free? And then the last thing is, how does this wrapping work? Okay, so I just want you to stop and think about that for a minute. Again, people have got stuff in the chat, which is awesome. Yep, short stretch. Yep, 50% overlap. Yep, perfect. Yep. Okay, good. All right, let's take a look. Short stretch bandages. Long stretch bandages are like ACE wraps. We don't want to use those. They have too much resting pressure. So we use short stretch. Now I saw some people put some brand names in the chat. That's good. But remember, on the exam, there's going to be no brand names. So they're going to say short stretch. Yes, the overlap of the bandage as we go around should overlap 50%. We should tell them they need to wear it 24 hours a day. They can take it off to shower, bathe, but then it needs to go back on. Okay, so it's really 24 hours a day. Other things, we might want to use stockinette underneath before we bandage. Sometimes we use some padding. Maybe they have an area that needs to be padded a little bit for skin, or foam. So when somebody starts developing that tissue fibrosis, where the tissue gets hard, you can add some foam, like a not really soft foam. It's a little harder foam in those areas as you wrap, and it's supposed to try and help break up some of that fibrosis. We do want kind of a cylindrical wrap. So if somebody has like a real skinny ankle and then a lot of edema, sometimes we put foam around that ankle a little bit so that when we wrap, it's a little bit more of a cylindrical type of thing. Don't ever use metal clips or safety pins. Like we don't want any skin poking, damaging, whatever. How does it work? It's the layering. It's the layering that's helping. And we should put it on where there's less pressure in our wrapping as we go up. So we got that kind of a gradient, but it's more from the wrapping and the overlaying than the actual pressure of that bandage. We are going to go cylindrical, not figure 8. Yes, we need to wrap fingers and toes because we said they're going to have edema in their hands and feet. So we need to do that. We don't want to do is wrap their leg and forget their ankle and their toes and all the edema just go down to their foot. And you can see short stretch bandages, they stretch to about 60% at the length. But if you get an ACE wrap, like, from athletics or whatever, it's got 170%. And so it's just too high of a resting pressure. And those really shouldn't be used when people are like sleeping. So the short stretch are safe to wear 24 hours a day. Okay. All right. I'm trying to follow the chat. Yes, wrap fingers and toes. So is lymphedema the only thing short stretch bandages are used for, or do you use short stretch for all this? Yeah, we use short stretch in all stages of lymphedema, all stages. And this might help you too. The lymph vessels are right underneath our skin. And if we do too much pressure, we just shut them down and the fluid can't go anywhere. So we want to do some pressure, but if we do too much, we're actually going to make the problem more difficult. Okay, so we don't want to do that. Why the picture isn't wrapped? I'm not sure about that one. Can you re-explain how the wrapping is done? Okay, so yeah, the picture, I don't know if the picture is better over here. So this one doesn't show the toes wrapped. Maybe that's part of the problem. So the toes should be wrapped in the picture, yes. So we have smaller bandages that we would wrap the toes with. And then I usually put like a stockinette on, and then we start just doing the short stretch bandage. I'm doing a little tighter in the beginning, but I don't want to do a lot of tight, right? The bandage already has that 60% in it, right? So I'm doing some tight in that, but as I go up, I definitely want to ease up on that a little bit. So I am doing a gradient. This wrapping is done during the active phase, right? But at some point, we don't want to do this anymore. We just want them to get custom compression garments. Okay, so we're just going to do this during the active phase. All right, I'm going to keep us moving. Yeah, I'm going to keep us moving, but I'm going to leave time at the end for questions for sure. All right, in the chat, do you know any precautions or contraindications for people with lymphedema? So we don't do figure 8 because it's more about the layering, and we do figure 8 with ACE wraps because the ACE wrap can get too tight. So we don't want to do cylindrical with ACE wraps because we can cut off like circulation because it gets too tight. But because we're using short stretch, we can do cylindrical. And it's more about the layering than the stretching of the bandage. Do you use ointments under the bandage? I usually don't, but if they have really dry skin, you can put something on for their dried skin and then wrap them. Okay, precautions, contraindications, no heat. Yes. Yeah, we want to avoid heat. Proper hygiene, keep it clean, moisturized. Yep. What else? Somebody has lymphedema. They come in. Okay, aquatics. E-stim ultrasound, no tight jewelry. Okay, all right, let's take a look. They want to avoid extreme temperatures. Somebody said heat, but also cold. So we got to think about our modalities. We don't have modalities in our complete decongestive therapy. It's not part of it, right? We listed it, right? Manual lymph drainage, compression. We didn't list modalities. Okay, that's not a typical thing. They need to protect their skin, avoid sunburns, that would be bad. Avoid any limb constrictures, right? So we should never take blood pressure in their arm where they have lymphedema. Take it in the other arm. Okay, now sometimes they have bilateral. So if we can take blood pressure in their leg, we can do that, or in a different way. Okay, tight clothes, tight jewelry. We should educate them. They should never allow somebody to take blood or start an IV or do a test for blood sugar with a pinprick. On that extremity where they have lymphedema, that extremity needs to be protected. Like, we don't want that to happen. Any high pressure, again, will occlude lymph flow. So let's say somebody doesn't have lymphedema, but they had a mastectomy on the right side with some lymph nodes removed. I wouldn't take their blood pressure on the right side. I wouldn't. I'd do it on the left, right? Because I'm thinking they're at high risk for getting lymphedema. I'm going to take it on the other side. Poorly controlled cardiopulmonary. Let's say they have heart failure or renal failure. We now have to think about, do we really want to do manual lymph drainage and compression and move all this fluid back to the core, to a heart or to kidneys that can't manage that? This is where we need to have a discussion with the medical team. They have lymphedema. I want to treat it, but yet I also know they're in, stage 2 heart failure. What are we going to do? Okay. But you should not just wrap. You should step back and say, wait a minute. This might, kill them, right? So you want to think about that. Severe arterial insufficiency. If somebody has poor blood supply in their extremity because they have arterial insufficiency, we don't now want to wrap them and do compression, because now they're going to have less arterial flow and now they can get ischemic. And so again, this is a conversation with the medical team. Yeah, they have lymphedema and I want to treat it this way, but they also have severe arterial insufficiency. So what are we going to do here? And then strenuous exercise exacerbates lymphedema. The other thing we should not do with people with lymphedema is high risk activities. So if somebody has lymphedema of their arms, I don't want them going out and doing martial arts, right? If it's a high risk of them getting an injury, that's not the kind of exercise I want them to do. Okay, good. All right, when using intermittent pneumatic compression or when prescribing somebody a custom garment, what is the appropriate pressure for somebody with lymphedema? I think this is a good question for the exam. Okay, somebody says 20 to 25, 20 to 30. Okay, you're going lower. I like that. Okay, yeah. All right, so let's look at it. Yes, the upper extremity, you're going to do less than the lower extremity. So there is a difference. 30 to 45. Okay, I'm liking it. Okay, good. So in general, when we do, this is general, this isn't lymphedema, but in general, whenever we do intermittent pneumatic compression, we never exceed somebody's diastolic blood pressure. So, or go over 70. Okay, that's in general. But for lymphedema, we have to be less than that. Again, we're going to shut down those lymph vessels. So they say that for good, helping the fluid flow through the lymph system, we have to be above 30, but we really don't want to be more above 30. So when we're doing our wrapping, we want to be between 30 and 45. Now that's during our active phase. Once their limb plateaus. I've been doing all this wrapping. I can't get it anymore. It seems to plateaued. Or their girth is the same. Okay, the right arm is now the same size as the left. Now I'm going to do compression garment. Now I'm going to measure them and order a custom compression garment. Now I want that garment for the upper extremity to be about 20 to 30 because I'm just maintaining now. I would go to the more 30. And for the lower extremity, I need to be higher. So probably around that 40. Okay. And then garments, usually insurance will pay for two, one that they wear, one that they wash, and about every 3 to 6 months, they're going to need replaced to keep them with the right pressure. Okay. All right, I think we're getting to the end. I got 10 minutes. Oh, good. I think we're getting to the end and we'll have some time for questions, which I'll stay on no matter what. But what are other problems a patient with lymphedema may present with that you may that you may put in your plan of care to help with? What other interventions might they need besides our complex decongestive therapy? Weakness, yes. Yeah, they'll stop using that extremity, especially the upper extremity. If I had lymphedema of my left arm and I'm right-handed, I may stop using my left arm. Well, then guess what? It's going to get weak, right? So that's going to be an issue. General deconditioning, absolutely. Yes, absolutely. Poor conditioning, yes. Cancer PT, most of the people we see with lymphedema have had cancer treatment. And so they're going to have other issues like cancer-related fatigue from their interventions and things like that. So we would address that as well. Range of motion, yes. They're going to get restricted range of motion because they've stopped using their extremity, or it's too heavy, or it's too, it's too edematous. They can't bend it. Next thing you know, we've got decreased range of motion. Yes. Endurance. Yes. Cancer fatigue. Right. Perfect. ADLs, yes. Balance, gait, absolutely. Yeah, wound care, absolutely. Perfect, perfect. People's posture can change. If I have one arm and it's very swollen, I might hold the arm and shift the way that I posture myself, and I can have postural changes. Gait changes if it's in your legs, even if it's in your arm, you might just change the way your posture is, and then you're walking differently. Wounds, fungal infections, decreased strength, range of motion, ADL. Now they're going to have problems with dressing, bathing, right? Yeah, you got it. Transfers, going up and down stairs. I mean, so we want to look at the person holistically. Let's not just say, oh, okay, I'm going to do my complete decongestive therapy and then that it ends there. Yeah, we would never do that. Prognosis, it's a lifelong management. Do not guarantee a patient that you're going to get their involved extremity to look exactly like they're uninvolved. We don't want to guarantee that. We're going to try as best we can to get the swelling down so that both limbs look symmetrical, but we don't want to guarantee that because especially if we pick them up later in the later stages, that might be difficult. Later stages, the tissue's already gotten hard, that might be difficult. Prognosis really obviously varies on the individual. The sooner we see them in the earlier stages of lymphedema, the better the prognosis. The length of time, right? The less length of time they've had it, the better prognosis. But it also depends on how many lymph nodes did they have removed? What was the extent of their radiation? Do they have scar tissue? Did they, all of that. Comorbidities, are they obese? Overweight, caregiver support. It is hard to do that wrapping on yourself, especially if you're trying to wrap an arm. So caregiver support can go into prognosis. The biggest thing is compliance. So, and compliance is hard. Think about it. Let's say it's summer and it's 90 degrees out and you're going to a picnic. Do you want to wear your compression garment? No. Okay. So, I mean, it's lifelong management, and it's very easy for somebody to not want to do what they need to do. And compliance is really probably the biggest thing that impacts prognosis. And so, prevention of frozen shoulder. I like that one too. Good. So we really need to, when we talk to patients and educate them, we need to emphasize this. I'm going to show you all these things, but you have got to do them. And unfortunately, it's going to be a lifelong thing. If you don't, then you're going to progress it can progress, and then you're going to have all these other issues. So we want to not scare them, but we want them to take that seriously. Stage 0 and stage 1 won't always progress. And so really important that they're compliant. We can prevent somebody from going from 2 to 3 or from 1 to 2. Yes. So again, if we can get them early, the better prognosis, and that compliance is a big thing. Especially if somebody with stage 0, I mean, they don't, it's going to be hard for them to comply, and they probably won't a little bit because I don't see any edema. Like my hand looks fine. Yeah, but you're saying it's heavy and it's fatigued. It's probably stage 0. They're really probably not going to want to wear that compression garment. But if we can get them to do it as much as possible, that would be great. Yeah, the stage 0 is like that latency stage. And then stage 1 is it can be reversible, but we don't know that it will be. So we don't want to be like, oh, you don't need to do all this stuff because it'll reverse. We don't know that. So we want to say it could, but let's do this. Diagnosis is from signs and symptoms and history and all that, but they can do a Doppler ultrasound, but it's not definitive. What they really have to do is this lymphoscintigraphy. Basically, they put radioactive dye in the lymph system, and then they look at a bone scan, and they can see, not a bone scan, it's not a bone scan, it's a scan that's kind of like a bone scan, but it's a scan, and they can see where that radioactive dye is accumulating. So in normal, I mean, we're going to see it normally in some things, but if you look at that far picture, that C, you can see that right leg, clearly it's sitting there in that bottom of that right leg, and they're like, okay, this really looks like lymphedema. And this is how they determine if there's blockages too in the lymph system. I just put this up just to remind you the lymph system just isn't the vessels and nodes, right? We have all this other stuff in the lymph system, which but just kind of throw that in there. Okay, so as a summary, you're going to have 1 or 2 questions on examination. Examination can be history questions. What are they feeling? Do they have heaviness, fatigue? Are their clothes fitting tighter? What in their history might suggest a cause for that secondary lymphedema? We can palpate lymph nodes. We can examine the girth and take measurements and do, again, our holistic examination and look at strength, and that's going to be our examination. Differential diagnosis, you're going to see 1 to 2 questions there. They're going to look to see, does this sound like lymphedema? Does it sound like lipodema? Could it be venous insufficiency? Could it be something else? Could it be a DVT? Could it be an infection? Questions on, well, what stage of lymphedema is this? Okay, what are we going to do about it? What's the prognosis? Okay, and then intervention, you're going to have most of your questions on intervention. And again, we went over all of those areas of that as well. So yeah, that is lymphatics. If you're looking for it in our books, lymphatics is with cardiopulm in the big book. And in the small book, I think it's with cardiopulm as well. These are some of the old. If you want to take a screenshot of this with your phone, this is what I always give my students and say, hey, do you know these things? Let's do a self-assessment. Okay, do you have good knowledge of these? Could you explain these? Could you teach these to somebody? If you do, you're probably good with lymphatics. And so that's kind of a little self-assessment I usually give my students to kind of look at that. Okay. All right. I'm going to see what else I got here. CPGs, if you aren't familiar with the CPGs, they are on APTA's website. So there is 2 for lymphedema. One's really lymphedema and one's really breast cancer, but they kind of go hand in hand. All right, those of you taking the exam in October, best of luck to you. We have 3 more weeks of online office hours. Here's the topics. I think next week is great, the mascurators of musculoskeletal pain. So this is when it sounds like musculoskeletal pain, but it's not. Okay, I think that's a really good one. Thermotherapy, like if you need to go over your modalities. And then the last one is knee ligaments and meniscal injuries. If you are not taking it in October and you're going to be hanging on, we are going to start back on November 13th. I always start us out with, just strategies for success, how you develop a study plan, all of that kind of stuff. And then we start getting back into topics. So the 20th will be primary care, differential diagnosis. You can see we got low back pain, obstructive pulmonary, and that kind of stuff. All of these are recorded. They are put on YouTube. This one will go on YouTube in the next couple days. And I think last week was a cardiac topic on cardiac cycle and ECGs. If you missed it and you're like, oh, that would be great, just check out our YouTube channel. Okay. All right, let's look. We got questions here. Is there a latency phase between lymph damage and when we might see lymphedema? Yes. Yes. So it develops very slowly. So everybody who gets a mastectomy and has nodes removed and stuff should be educated about the possibility of lymphedema because it may not occur for a year later. So yes, doesn't mean they have it or in stage 0, but it's probable the possibility is there and they should know about it, if that's your question. Somebody mentioned aquatics. I've not heard that aquatics can't be used. Aquatics does give some pressure to the extremity, but it's not huge. I think aquatics is fine if they don't have any openings in their skin, they don't have an infection, like they don't have, something else that would keep them out of the pool, like heart failure or arterial insufficiency. But if they just have lymphedema and their skin's intact, I don't see why they couldn't go in the pool. Now, we don't want it hot though either. So as long as the pool's not like a warm pool, that would be good. What other questions? Are there stages in lipodema? No, there are not. There are no stages in lipodema. I didn't tell this story, but I had a friend of mine who she's musculoskeletal sports PT, but for a little while she decided she wanted to do lymphedema and she went into it. And I don't know where she was practicing, but she said she just kept getting referrals from physicians with people with lipodema. And she kept trying to educate the physicians that, what I do is not going to help. Like they need to do weight loss, they need liposuction, other things like my complete decongestive therapy is not going to help somebody with their, lipodema. So is there a time after that they have no longer risk for it? So if they've had surgery and they've had nodes removed and everything, and they don't develop lymphedema, at some point in time, could we say they're no longer at risk for it? I don't think so. However, because as we get older, right, or if we get heavier, or there's other things that happen in our life, and they don't have the best lymph system, I think it could develop later. However, I think the chances of it go down. So if somebody said, yeah, I had breast cancer 10 years ago and it's very low risk, probably. I don't know what the risk would be, but I don't think it's very common then that somebody would 10 years later develop lymphedema. So there is my email address. If you need anything, you can write that down. You can continue to email me and ask questions.
I'm sorry, could I actually ask you one more question?
I was just going to ask if anybody wanted to ask any more, put it in the chat or unmute. Yeah, go.
I'm still kind of confused on the intermittent pneumatic compression pressure. Like,
Yes.
how do you could you re-explain that? And I'm confused on how you get the numbers. Do you take blood pressure to get these numbers? I'm just
Okay.
confused on that completely.
Yeah. Nope, that's good. That's good. So I teach intermittent pneumatic compression to my students, but we're not talking about lymphedema. We're just talking about it in general. And we never go over somebody's diastolic blood pressure or 70. So my students, when they come into a practical, they have to take the blood pressure because most people, they're going to be 70 or above. It's fine. But say my diastolic pressure is 60. That means they can't go above 60. Okay. So that's just general. So let's say you have somebody who comes in the clinic and they've got severe ankle sprain and you decide you want to do intermittent pneumatic compression, you would take their blood pressure and you would make sure you don't go over their diastolic pressure, or you don't go over 70. Okay, 70 is the highest. All right. But for lymphedema, it's different. So for lymphedema, if I'm treating somebody's upper extremity, I'm usually shooting for 30 to 35. If it's somebody's lower extremity, I'm usually shooting for about 35 to 40, maybe 45. I don't take their blood pressure because I'm hoping nobody's diastolic is 30, right? So I don't have to take their blood pressure. I just know because they have lymphedema and I'm going to do lower pressure, upper extremity, I'm shooting for that 30, 35, lower extremity, 35 to probably 45. And I'm not going to go any higher than that. Does that help?
Okay, that's very helpful. Thank you.
Okay. Yep.